As you all know, mitral stenosis is the hemodynamic manifestation with the elevated LA pressure along with reduced cardiac output as a result of obstruction across the stenotic mitral valve. And in rheumatic mitral stenosis, it is the commissural fusion, the medial and lateral commissures fuse, and there is thickening that results in this. Now, simple methods of calculation of the valve area is the 2D derived planimetry calculation. This is a direct measure of mitral valve area, does not involve the hypothesis regarding flow conditions, cardiac chamber compliance, or associated valvular lesions. Best correlation with the anatomic valve area and explanted valves. But only problem is we may not be directing our beam towards the tip. Here comes the advantage of the 3D echocardiography. Here, this is the biplane view where this can be placed right at the tip so that you have the valve area on the orthogonally opposite plane, that is on the right hand side. So this is the mitral valve, and if you place this cutting plane and right on the opposite side you have the biplane view of the mitral valve where you can carefully write it. Similarly, you can use the triplane view to identify the correct form of jet, and these are some of the latest advantages here. This is you can view from the mitral valve from the left atrial side. This is the view from the left ventricular side, and this is called as the flexi view, where the valve area can be identified very easily. So this is the mitral valve. As you have the transesophageal transducer, you identify the aorta and it has to be rotated and kept at the 12 o'clock position. This is the biplane view, transesophageal biplane view. And then you rotate, then keep aorta, and then you see here, this is the anterior mitral leaf flare, this is the posterior mitral leaf flare, this is the lateral commissure, and this is the medial commissure. Both are fused, and you can clearly spot the mitral valve, which is stenotic. This is left atrial appendage. You always view the end-on view. So that is how you look at the mitral valve and calculate the mitral valve orifice area. Now coming to the transmitral gradient. Mitral stenosis is characterized by elevation of the left atrial pressure as a result of impairment of the mitral valve opening and LA emptying. Severe AMS is defined by mitral valve area of less than 1.5 square centimeters. Initially we were taught that it is 1, now it has been 1.5. But even with this degree of narrowing, mean mitral gradients can vary considerably given their dependence on flow, stroke volume, and heart rate. This is relevant to patients with mitral stenosis where stroke volume is impacted by the fixed reduction in left ventricular preload and from the mitral valve impedance to the LV filling. Stroke volume can additionally be affected by direct extension of the inflammatory rheumatic process to the subvalvular apparatus and adjacent basal myocardium, impeding ventricular systolic and diastolic performance. Furthermore, the development of atrial fibrillation or pulmonary hypertension secondary to mitral stenosis or common age-related comorbidities such as hypertension and coronary artery disease can all independently affect the cardiac performance, lowering the stroke volume. So this is the classical pressure gradient, and you can trace the mitral forward flow with a continuous wave Doppler, and you get the peak gradient as well as the mean gradient. Peak gradient is 24 and mean gradient is 13. Now what happens with pressure half time is that It is a time interval in milliseconds between the maximum mitral gradient in early diastole and the time point where the gradient is half the maximum of initial value. And the simple formula is 220 by pressure of time. Now I will show you an illustrative case where how this mismatch occurs. This is a young man, only 24 years. He came with breathlessness and disease. You can see here, this is the Biblian view showing clearly the stenotic mitral valve. This is the transesophageal triplane view. And you see the gradient. The gradient is around 40 and mean gradient is 22. And this is the 3D mitral valve area calculation. This is 0.5. This is the flexi-like view where you can identify the valve area very clearly and you can plot it. And there is usually a difference between the 2D and 3D. 2D areas tend to be higher and more accurate correlation of the 3D valve area occurs with the cat derived data. Now what happened is that because this patient had a LA appendage clot, the balloon mitral valvuloplasty was delayed and he was advised anticoagulants. He came after 3 months and see what has happened. He has developed atrial fibrillation and see what has happened to the gradient. The P gradient is 26 and mean gradient is only 15. And the pressure of time mitral valve area varies. So the ideal way is here to calculate the planimetry and do the calculations. And this is the clot you see here. The clot has extended. And when you see into the left atrium, you see even on the left atrial wall, there is clot debris. So patient underwent, I suppose the surgeon was supposed to take for mitral valve repair, but ultimately he had valve replacement. This is the final. The prosthetic bileaflet valve was replaced. So this happens. The valve area remains the same, but due to the development of the atrial fibrillation, the patient has undergone the mismatch. So what is the algorithm for this patient is mitral valve area less than 1.5. If it is rheumatic and the mean gradient is more than 10, and you have to go according to the ACC and ESC guidelines. And if the mean gradient is less than 10, stress echocardiography can be done and to find out whether it increases and the pulmonary pressure also increase. So if it is more than that, you can go for balloon valvuloplasty for the rheumatic cases. In mitral annular calcification, regenerative valve replacement, percutaneous valve replacement can be done. So this syndrome is now labeled as low flow, low gradient mitral stenosis. This is seen among patients with severe mitral stenosis and is a subset with low output and low transmitral gradient. Patients with low flow, low gradient severe mitral stenosis had higher arterial afterload, greater prevalence of atrial fibrillation, and more subvalvular thickening and decreased left ventricular compliance compared with those with high gradient mitral stenosis. Clinical implications are that patients with low flow, low gradient severe mitral stenosis had less symptomatic improvement, that is very important, after valvuloplasty. Mitral valve gradient rather than area had the best predictive value for symptomatic improvement. So that is the importance of gradient. However, there has been a shift in the demographic characteristics of mitral stenosis, at least in the western half. Still, we see younger patients with mitral stenosis in our part of the country. The mean age of the patients with low flow, low gradient mitral stenosis was 73. This is one large study results from the large study with 50th year in older in epidemic studies of patients with rheumatic MS. Age-related cardiovascular changes including aortic stiffening and LV non-compliance similar to what is seen in heart failure with the preserved ejection fraction may confound the presentation of rheumatic MS. Despite the long-held theory that rheumatic MS is an isolated disease of mitral valve, a number of preliminary studies have identified LV myocardial abnormalities and an increased afterload in subset of the patients with mitral stenosis. So this you can see here the outcome of valvuloplasty in low gradient versus high gradient. This is a low gradient mitral stenosis. This is high gradient mitral stenosis. You see here, no symptomatic improvement is seen in 40% of the patients with low flow, low gradient mitral stenosis. Whereas in high flow, high gradient mitral stenosis improvement is much better. And this is person survival. Low flow, low gradient. This is low flow, low gradient survival compared to the high flow and normal flow. This is the determinants of stroke volume in severe mitral stenosis. You can see here the effect of atrial fibrillation and the effect of the aortic stiffening. So this is high gradient mitral stenosis, which you see here, and the mean gradient is more than 10. This is low flow, low gradient mitral stenosis, where the mean gradient is less than 10. Classically, the rhythm is atrial fibrillation. Now, there is another category which is called as normal flow, low gradient mitral stenosis. This group had higher mitral valve area and lower LA pressure by catheterization compared with high gradient mitral stenosis group. And this group had a lesser degree of reduction in mitral gradient, mean gradient and LA pressure after valvuloplasty and had the most favorable long-term outcomes. This suggests that this group represents a less severe form of mitral stenosis. The clinical implications are that among patients with mitral stenosis, overall mitral valve area, whether measured by echocardiography or by catheterization, did not predict symptomatic improvement. This, in addition to a recent study on aortic stenosis, suggests that the assumption of underlying valve area calculations may be less accurate in predicting functional significance compared with the gradient measurements. Now, what is pseudo-severe mitral stenosis? Given the decreased hemodynamic benefit afforded by valvuloplasty in patients with low gradient mitral stenosis, functional assessment with pharmacological manipulation of arterial afterload with vasodilator testing agents may help determine which of the patients with low flow, low gradient mitral stenosis have true versus pseudo-severe mitral stenosis and enable better selection of candidates who are likely to benefit from valvuloplasty. For patients with pseudo-severe MS, simple afterload reduction to improve vascular stiffness may be all that is indicated to improve the filling pressures and symptoms. So, stress echocardiography may be helpful. So, this is a degenerative MS where there is a low gradient. Low gradient, you can see here the valve area compared to the valve area. So, that is degenerative. And in congenital MS also, you don't have a higher gradient. This is mucopolysaccharidosis, one case of meniscopostenosis, and the gradients seen. And similarly, this is another patient with parachute mitral valve. So, balloon is not possible in these patients. So, this is another double orifice mitral valve. So, thank you for your kind attention.